Good evening. I would like to welcome you to the symposium, and I am Salah Zainuddin, and I'm really glad to be chairing the session and introducing the two speakers, Dr. Mirna Waked and Dr. George Velikian, both pulmonologists and critical care physician at St. George Hospital, Bellarmine University, and they're both very good friends and people who are really worth listening to. And I would like to welcome Dr. Waked to the podium now.
Thank you, Mr. Chairman. I will talk about clarithromycin or macrolides in general, and insisting on one aspect which could be a very interesting aspect for the future is the other, let's say, effect of macrolides other than the antimicrobial effect. Just to remind you that it is a macrolide, and it was invented it was invented for a purpose, because there were a lot of efforts to develop a version of erythromycin which has a better acid stability and not causing side effects such as nausea and stomachache. And clarithromycin gained FDA approval and was launched in 1991 in the US. Just also a very important quick reminder on the effect and or the spectrum of clarithromycin. They really cover the typical strep pneumoniae and catarrhalis, typical pathogens entering the cell in vivo like pyogenes and aureus and Haemophilus influenzae, and atypical. But they are inactive on the gram-negative bacilli, enteric gram-negative bacilli. So their indication as antimicrobial are mainly in upper respiratory tract infections such as sinusitis, tonsillitis, pharyngitis, and lower respiratory tract infection. We will not go and tackle the other indication like treating Helicobacter pylori, eradication, and skin and soft tissue infections. How do does the macrolides have effect? The mechanism of action of the antimicrobial activity is binding to the 50S subunit in the ribosome, where you have the synthesis of protein. By binding to this unit, they really block the synthesis of new amino acids, and by that they really block the bacteria from manufacturing other proteins that might be a mechanism of resistance to antibiotic. Also, a quick reminder that the inflammation in general is not only a bacterial inflammation or infectious inflammation, it's a non-specific immune response of tissue and blood vessels to injury or infection. It might be due to trauma, chemicals, or bacterial invasion. And still, the four classic signs of inflammation, pain, swelling, redness, and heat are still available and still really valid. And during inflammation, we all know those 3 or 4 steps that we go through. Inflammation, as a general phenomenon, not only infectious, is really a feature of chronic respiratory disease like an asthma, in polyposis, cystic fibrosis, or bronchiectasis. So, what is it about the other effect, a possible other effect of macrolides other than antibacterial effect? In the 60s, it was observed that macrolides might have a sparing effect of the use of steroids, and especially in dependent asthma to steroids. And later on in the 80s, they reported a remarkable effect on pan-bronchiolitis by erythromycin treatment. And over the last decade, there has been an interest in the possibility that these drugs may be effective also in non-infectious chronic rhinosinusitis. So, what could be the possible mechanism of action of the macrolides other than the direct effect on the bacteria and the direct effect on blocking the synthesis of proteins by the bacteria? The first possible non-antimicrobial effect would be to have an effect on cytokine production. And this is from a recent study, but in ENT, where they looked at the level of IL-8 and metalloproteinases oxidase that were elevated in nasal secretions of chronic rhinosinusitis. And as you see, compared to controls, those who have chronic rhinosinusitis have the baseline very high IL-8 levels. And by the week 12, treated by clarithromycin, we had a drastic and significant decrease in IL-8. Okay, so cytokine production, inhibition of cytokine production could be a mechanism of the non-antibacterial effect of macrolides. Another possible mechanism of action is to have an accelerated death of the neutrophils called the apoptosis. And this is also another experimental study where they look to the survival of the neutrophil, and with time, with different doses of erythromycin. And as you see, the survival of the neutrophils is decreased according to the higher concentration. It is dose dependent. The higher erythromycin, the less survival of neutrophils. Again, this is another study where the effect on apoptosis of the macrolide on neutrophil survival was also compared to control using different kind of macrolides, where you have the clarithromycin having a significant effect, like the roxithromycin, and compared to the penicillin that had no effect in this part of inflammation. Another possible mechanism is an effect on oxidative burst, meaning that studying clarithromycin compared to control and erythromycin, there is a significant effect in reducing the production of toxic reactive oxygen species, which are released by eosinophil and neutrophil in inflammation. What is the effect also on adhesion molecule expression, which is a very interesting change, which is very important to be expressed on the surface of the leukocytes. Whenever they are activated, the adhesion molecules are activated when you have a release by inflammatory cells of chemokines, which will permit to the neutrophils and the leukocyte to adhere to the vessels and the site of inflammation despite the ongoing blood flow, and this will permit definitely a better defense and a better activation of the neutrophils. Again, this is also another study where also the erythromycin with different concentration is seen to be very effective in reducing the release of soluble ICAM1. The effect also on mucociliary clearance would be also to stimulate the ciliary beat frequency, and in this case, the improve in mucociliary clearance is possible with also the macrolides. So, and also the mucus production will be reduced overproduction will be reduced by the clarithromycin, and also decreasing of the expression and production of mucus or excess mucus in epithelial cells. So there was the possible mechanism of action of the macrolides, the non-antimicrobial effect. And the other effects, and this is probably the core of the efficacy of these part of antibiotics on bacteria, is the other effects is the inhibition of the quorum sensing and biofilm formation. This is very interesting, and I think the very new way to look at the effect of antibiotic on the bacteria. The bacteria communicate with each other using signaling molecules. They have a kind of very intelligent way to communicate and to see the danger coming, and this is due to what we call the pheromones. The bacteria are also able to measure the number or concentration of the molecules within a population. So what we call the quorum sensing, as it is a signal for the bacteria to really start by developing a mechanism of defense and accumulation of by accumulation of signaling molecules, and this will sense the number of bacteria and the cell density, and they will develop a kind of defense. So they will be able to adapt. They will really have an important coordination to improve their virulence and to develop a resistance to antibiotic. So this is the biofilm, which is really defending or around the number of bacteria. This is the biofilm formation, which is also sensed or excited by all the what is released as homoserine, proteases, exotoxin, piocyanin. All these signaling molecules will help the bacteria to get around, to help each other, and to have this what we call quorum sensing and developing the biofilm, which will protect it. So the bacteria will attach to a site of infection, will be growing but protected in this biofilm, and after growing and multiplying, they detach in a very special way. So definitely the quorum sensing and biofilm formation is dependent on host response, liberation of inflammation and mediators, and accumulation of neutrophils, and also the virulence of the bacteria is also important. All this will have an impact on the importance of the infection. Macrolides will have an effect on decreasing the factors of virulence, decreasing the biofilm formation, and also an effect on host response. By that, it will add on a benefit to reduce the virulence of the bacteria. And this is the same concept where you have this circle of liberation of by the macrophage epithelial cell of chemokines, which will attract the neutrophils and amplifying the inflammatory process by the bacteria. And this is how the macrolides will interrupt this cycle. So what would be the macrolide we can use in this case, a non-bacterial effect? The clarithromycin is the most studied in controlled randomized study. Azithromycin has been used widely in long-term treatment in cystic fibrosis, especially in cystic fibrosis, but you don't see it in very large controlled randomized study. So apart from their obvious antibiotic effects, the macrolide have some potentially useful immunomodulatory effects, and they inhibit the production of certain cytokines, and they have a very interesting effect. And this effect, anti-inflammatory effect, is not steroid sensitive, and this is a very interesting perspective in the clinical experience and in this case. So the potential to reduce the virulence of some bacteria may be an important feature in reducing the tissue damage that you can see in chronic infection. So long-term, low doses of macrolide treatment can give us a symptomatic relief to majority of patients with severe chronic, like say just an example of sinusitis. So just few quick results of some, let's say, not guidelines, but some possible, let's say, places we can use the macrolides in a practical cases. What about macrolides and COPD? It is definitely an interesting part, and macrolides are really considered a new perspective as anti-inflammatory and immunomodulator in COPD when you have an inflammation and oxidative inflammation and proteases inflammation. We have several studies showing a reduction in exacerbation in COPD, and this definitely is something for the future that could be studied in prospective way. In asthma too, there is also could be a place for the clarithromycin in asthma patients who are resistant to steroids, and the effect of clarithromycin as anti-inflammatory is really deserving a better and probably bigger studies, prospective studies. In cystic fibrosis, there is definitely a place for the use of macrolides for the chronic colonization. In bronchiectasis, again, there is several studies with short-term or long-term use of macrolides that look to a better improvement of respiratory capacity when using macrolides. For bronchiolitis, it is well established that they have beneficial effect in improving respiratory capacity. In cryptogenic organizing pneumonia, there are some perspectives, but not yet really well established. We need better and more studies to really place the macrolide as anti-inflammatory in cryptogenic organizing pneumonia. And in viral infection, we need still other results. In nasal polyps, it could be interesting in the nasal polyps which are not steroid sensitive. And so I just really finish with a few articles which I recommend on the clinical effectiveness of macrolide in diseases of the airways, and interesting review in the European Respiratory Journal in 2012. Very interesting references that I really hope that you can also consult, because they are very extensive in explaining the non-antimicrobial effect of macrolide. Just one thing that has been appearing in the literature recently, pinpointing a possible effect of clarithromycin on heart, could give heart problems in COPD patients, but the cause effect was not really well established. So, and the group of COPD patients where the heart problems were discovered and could not be linked to the use of clarithromycin because of the baseline situation of those COPD patients who are prone to have heart problems independently of the effect or the use of macrolides. So this is just to finish that it is an interesting perspective, could be interesting for us as pulmonologists to use it in COPD to reduce exacerbation in resistant asthma, and probably and well established in bronchiolitis obliterans. So this is it. So I will just give the floor to Dr. Juvelikian, who will be exposing some of the cases where clarithromycin has been used in another indication than antimicrobial. Thank you very much.
Good evening. Thank you for waiting till now. This is impressive. Thank you, Mr. Chairman, for your chairing of this session. I will actually go over a couple of cases, actually exactly 2 cases, that will probably highlight some of the non-bacterial effects or antibacterial effects of clarithromycin. Pay attention, please, because I will only do this once. This is a case that I saw in 2010. This was a 27-year-old male who was previously healthy on no medications. He was a never smoker, and he worked in an office setting as a civil engineer. Developed what looked like a regular upper respiratory tract infection, chills and body aches, and so on and so forth. That was the fall of 2010. The symptoms resolved a few days later, but he was left with a slightly productive cough. And a month later, he had bilateral expiratory wheezes, along with the slightly productive cough. He was started on inhaled corticosteroids and a short-acting beta agonist on an as-needed basis, following a short course of tapering steroids. Following a period of improvement, he was re-evaluated in early February for worsening dyspnea, with cough that was still minimally productive, and the exam again revealed bilateral wheezes. He had no upper respiratory symptoms left. Chest X-ray was normal. He was restarted on inhaled corticosteroids, and long-acting beta agonist was added when his symptoms failed to improve. A few weeks later, he still had the slightly productive cough, but his dyspnea was getting worse. He was still on a combination therapy. The exam revealed diffuse wheezing and scattered bronchi. The saturation for a 27-year-old was actually quite reduced to 93% at rest with a tachycardia of 103. Spirometry was done, and I don't know if you can look at the numbers, if they're obvious, but essentially he had a severe obstructive process with an FEV1 of 45% following bronchodilator response, bronchodilator administration. So he was actually quite obstructed at that time. The chest X-ray again was normal. Serology for mycoplasma and chlamydophila were obtained, and he was given a course of clarithromycin in addition to another tapering course of oral steroids. He was kept on his combination therapy. He improved drastically over the following days. The serology a few days later returned positive for mycoplasma, and the spirometry was repeated. Now this was, I think, it was about maybe 8 days later, and as you can see, his numbers got much closer to normalcy compared to the initial spirometry, and there was no bronchodilator response left following administration. A month later, he had clear lungs. Their medications were tapered to a short-acting beta agonist to be used on an as-needed basis, and he has not needed any bronchodilators since that time. So essentially, he was cured. I will review a few articles that may make sense of what happened with that case, and maybe try to give us some guidelines on when to consider a macrolide in our asthmatics. So this is a study from 2008 on severe asthma exacerbation, the role of atypical bacterial infections. And essentially, there were 69 patients with an acute exacerbation of bronchial asthma. The 58 that were included ended up with 48 discharged home and 10 admitted to the emergency department. Now, all those patients were checked for acute atypical infections via serology, and of those 58 patients, 22 had evidence for an infection with an atypical organism. 19 of them had chlamydophila pneumonia, 2 of them had mycoplasma pneumonia, and 1 had both. Those patients were actually found to have a discrepancy in their bronchospasm and in the severity of their bronchospasm. It turned out that even though all those patients had bronchial asthma that was not well controlled and had an exacerbation, those that had the acute atypical infection seemed to fare worse in terms of their lung function and their response to therapy. On the first, these patients were followed on 3 visits. On the first visit, the patients with the atypical infections showed significantly lower FEV1 compared to the other group, which was here used as a control to some extent. The FEV1% difference remained statistically significant at visit 2, and it wasn't until the 3rd visit that there was no longer statistically significant difference between the two. Those patients did receive the macrolide clarithromycin in that case, and they fared better. Another study on airway microbiota and bronchial hyperresponsiveness in patients with suboptimally controlled asthma. And this actually can bring into focus probably what Dr. Waked was discussing, much less so in terms of biofilm, but the same principle that the airway of asthmatic patients that are not well controlled seems to harbor bacteria. And when that pilot study was done, they took bronchial epithelial brushings on those patients, 65 adults essentially, with suboptimally controlled asthma. So none of them was a controlled patient. They were suboptimally controlled, either uncontrolled or partially controlled. And they got the swabs, the bronchial epithelial brushings from them via bronchoscopy. And they gave them clarithromycin, and they kept 10 healthy control to compare them to. And they looked by checking via a certain way. They checked the 16S R ribosomal RNA to check for 100 different strains of bacteria. And they found that the 16S ribosomal RNA bacterial burden in the bronchial brushings from asthmatic patients and healthy subjects, when they compared them, they found that asthmatic patients exhibited a greater bacterial burden compared to the healthy subjects. This is the what the kit tested for. These are the 100 different taxa that were checked in that kit from the bronchial brushings that were obtained. And essentially that analysis revealed that variability in airway microbiota composition was correlated with both the degree of airway hyperresponsiveness, so those patients who had worsening asthma or had an increased bronchoconstrictive effect, they seem to have a higher concentration of those bacteria and the bacterial burden per se. This suggests that the types and relative abundance of the bacteria present in the airways are associated with these two variables. Again, I highlighted in red because I think that may have some message for us in our clinical practice, especially when we meet patients that seem to be difficult to control or otherwise don't seem to have a clear-cut reason why they would fail our standard therapy. Asthmatic patients possessed greater airway microbiota diversity than the control subjects with a significant p-value. Their methacholine PC20 concentrations were inversely correlated with the diversity, suggesting a strong relationship and probably a two-way relationship. That presence of microbiota made their asthma worse, and the fact that they had a bad asthma contributed to the worsening of their bacterial load. So airway bacterial diversity was significantly greater in the asthmatic subjects who demonstrated a significant reduction in bronchial reactivity in response to clarithromycin treatment. So again, we gave them clarithromycin and there was a positive effect on both ends. So among adults with suboptimally controlled bronchial asthma, bronchial hyperresponsiveness correlated strongly with airway microbiota composition and diversity. And because a lot of those taxa included atypical bacteria, it would be wise to use something that would have a spectrum that would cover for those as well. Another study from Michael Kraft, this is mycoplasma pneumonia and chlamydia pneumonia in asthma, the effect of clarithromycin. This was a randomized controlled trial of 55 patients with chronic stable asthma who underwent airway evaluation for both mycoplasma and chlamydia by PCR and culture. And then were treated with clarithromycin 500 milligrams PO BID versus placebo for 6 weeks. PCR revealed positive for mycoplasma or chlamydia in 31 out of the 55 asthmatics. The treatment resulted in a significant improvement in the FEV1, but only in the PCR positive subjects, again denoting that the infection itself does confer a significant element of bronchospasm and airway hyperreactivity, and that may be why when those patients were given the macrolide, they fared better than the other group. Another study from the pediatric world, the importance of the acute mycoplasma pneumonia and chlamydia pneumonia infections in children with wheezing. 71 children aged 2 to 14 with an acute episode of wheezing, and 80 age-matched healthy children were included. The sera for specific antibody levels and nasopharyngeal aspirates for detection of mycoplasma and chlamydia were obtained on admission and after 4 to 6 weeks. Acute mycoplasma pneumonia and chlamydia pneumonia infections were detected significantly more often in children with wheezing than in controls. And another study again, no, this is the same study, I'm sorry. Antibiotic was added on the basis of the judgment of the pediatrician in charge. They used 50 milligrams per kilo, which is a standard dose, and 10 days of therapy was used, and this is again standard. Among the non-antibiotic treated children, those with acute mycoplasma and or chlamydia pneumonia infection showed a significantly higher recurrence of wheezing than those without the acute infection with the atypical organism, and again the significance was valid with a P that was significant. So in those patients who were infected with atypical organism, microorganisms. If you treat them with the standard therapy for asthma and you do not cover for their atypicals, or you don't try to eradicate their atypical organisms, their likelihood of recurring and of having worsening recurrences will be increased. This is from a recent study, again in the pediatric literature, on the effect of clarithromycin on acute asthma exacerbations in children. And this was an open, randomized study and a pilot study that included 40 school-aged children with intermittent or mild asthma, persistent asthma, presenting with an acute exacerbations. They were randomized to receive the standard dose of clarithromycin for 3 weeks, in addition to their regular GINA-recommended exacerbation treatments. And again, those in the clarithro group had significantly more symptom-free days, less total number of periods with loss of control during the follow-up period compared to the control group, and reduced duration of the index episode. So they responded quicker, better, and they had less recurrences eventually. A few words on the second case. This is a case that you will probably rarely see, and this was a case that Dr. Waqid had in her practice, and she shared with us. A 22-year-old male patient works at a supermarket who had progressive dyspnea on minimal exertion and a history of smoking 1.5 pack years and a negative family history of any pulmonary diseases. At 15 years, he started to have dyspnea on exertion that was slowly progressing to dyspnea at mild exertion with one stair and around 100 meters. The first consultation was in July of 2010. He was thin, not in distress, and saturation was quite low at 91% on room air, and he had diffuse crackles on physical examination, and this was his scan. And it showed at the mediastinal level, mediastinal lymph nodes measuring 13 millimeters at the parenchymal level. They had diffuse, the patient had diffuse, I don't know if they're showing, but diffuse bilateral micronodular infiltrates that were central and peripheral in their distribution with peribronchial thickening. They concluded that he had bilateral diffuse micronodular interstitial lung disease. The spirometry showed a reduced ratio of 60% and post-measurement of 62%, with an FEV1 pre of 30% and post 35%, which goes with his clinical picture and his dyspnea and saturation. Small airways involvement was also noted, with a percentage of 13% and 15% before and after bronchodilator respectively. His TLC was quite restricted, with 46% predicted, and he was interpreted as having severe obstructive and restrictive lung disease, but with reversibility. All the studies were negative for autoimmune diseases, immune deficiency, infectious diseases, including anti-double-stranded DNA, SCL, ANCAs, ACE, alpha-1 antitrypsin, rheumatoid, HIV, and his PPD was also negative. Echo revealed a normal left ventricular function with a PA pressure that was borderline at 25. Mediastinoscopy and lymph node biopsy were done with no definitive result on pathology, reactive follicular hyperplasia. Patient was discharged from the hospital to complete a course of antibiotics, was given ceftriaxone, was switched to cefepime, and a tapering course of steroids. So 3 weeks from discharge, returns to clinic, 50% improvement in his cough, better lung examination, saturation slightly better at 93% on room air, and he was sent to complete a 2-month course of 50 milligrams prednisone, so essentially a reasonable dose, a PPI, antifungals, ICS LABA combination, montelukast, and acetylcysteine. 2 months later, improvement in cough, still functional and working, exam is better, saturation is now in the normal range. A month later, deteriorated again, admitted for dyspnea, cough, sputum, and desaturation. CT scan in October of 2010 showed extensive chronic interstitial infiltrates, predominating in the mid and lower zones with tree and bud appearance. The sputum culture was positive for Pseudomonas, and the patient was being treated with levofloxacin steroids and antifungals. An open lung biopsy and wedge resection showed cellular and follicular bronchiolitis pattern that goes with collagen vascular diseases, hypersensitivity reaction, immune deficiency, or idiopathic. So that was the differential. Again, the patient was given the mentioned treatment, did not show major improvement in his symptoms. A month later, in November, started on clarithromycin every other day with a tapering course of steroids that was stopped in January of 2011. Spirometry showed an improved ratio of 75% pre-measurement and 72% post-measurement, with an FEV1 that is now at 59% with no bronchodilator reversibility. A repeat CT scan of the chest showed a clear improvement. CRP was 4 and SAD rate was 3. Again, April 2011, so this is almost 8 to 10 months following the initial presentation. Spirometry showed another level of improvement. He was maintained on clarithromycin, combination ICS/LABA and Montelukast. He was stable in June 2011 till May 2012, a year. And from April 2011 till now, he is off steroids, on rescue bronchodilators, maintained on Montelukast and clarithromycin. And this is the scan from May 2012, was stating that the lung parenchyma clear of active infiltrates and gross nodular disease, with some peripheral subpleural bronchiectatic changes in the right middle lobe and the left lower lobe noted. Spirometry now is a ratio of 77% with an FEV1 that normalized at 86% and a CRP value of 0.2 and a SED rate of 6. A few words on follicular bronchiolitis that I had to learn. So follicular bronchiolitis is defined by the presence of hyperplastic lymphoid follicles with reactive germinal centers distributed along the bronchovascular bundles. Grossly, the lungs will show peribronchial nodules, 1 to 2 millimeters in diameter. And this form of lymphoid hyperplasia is a common secondary findings with patients that have bronchiectasis affecting the proximal large airways usually. In others, however, this is a manifestation of primary pulmonary lymphoid hyperplasia. In patients with primary lymphoid hyperplasia, peribronchiolar lymphocytic infiltration into the interstitium often accompanies the peribronchiolar lymphoid aggregates and overlaps with lymphoid interstitial pneumonia. Follicular bronchiolitis can be idiopathic or occur and associate with connective tissue diseases, especially RA, immune deficiencies, including HIV and AIDS, pulmonary infections, or ill-defined hypersensitivity reactions. It represents lymphoid hyperplasia in response to an extrinsic immune stimulus or altered systemic immune response, as seen in patients with RA. Patients present pretty much like our patient with progressive dyspnea, variable pulmonary function abnormalities, including restrictive, obstructive, or a mixed pattern. Predominant findings on chest X-ray is bilateral, small clusters of nodular or reticulonodular infiltrates with intrathoracic adenopathy, again, like we saw in our patient. The adenopathy was present, but it was not that impressive, but it was in the 10 to 15 millimeter in its larger diameter. The chest radiograph may sometimes look normal because the interstitial findings may be not detected on the regular X-ray. That's why the high-resolution CT scan would show the pathology of centrilobular nodules measuring 1 to 12 millimeters in diameter, variably associated with peribronchial nodules and patchy areas of ground glass attenuation. These are usually bilateral and diffuse in distribution, and we would see some mild bronchial dilatation with wall thickening in some cases. Mosaic perfusion, pleural effusions are not seen, and honeycombing is not seen, and that differentiates it from a lot of the other ILDs. Prognostic implication is unclear because there are not that many cases. The treatment, I will spare you, but it's everything that we've talked about. But in short, if you can find an underlying reason, you would go after that one. If not, you can use the standard therapy, including steroids, immune suppressants, steroid-sparing medications, and immune globulins. The emerging macrolide treatment is being used with good response, as with other pan-bronchiolitis patients, and this is why it was started in this case in the beginning. But again, like I said, this is not something to take home as dogma, but again, to keep in mind that there are some effects of the macrolide molecule that would separate it from the other antibacterials, and which may be indicated in some cases. This is another case report that I will only read the title of: beneficial response to macrolide antibiotic in a patient with desquamative interstitial pneumonia refractory to corticosteroid therapy. Again, I can't tell you much about the mechanism because it's not been in the article. They don't really have an explanation except that the patient did respond, and they tell you that in some cases of ILD it may be reasonable to consider, especially when we're stuck with poor response, some unusual approaches. And I will close by this from Current Opinions in 2012 by James Good. It summarizes with the following statement: because of their effect on protein synthesis, macrolides have both antimicrobial and anti-inflammatory properties. Both mechanisms appear to be important in their clinical efficacy in treating a wide variety of pulmonary disorders, including asthma. And I thank you for your attention.
Thank you.
Just to feel a bit better because our job stinks. It was something they test for different deodorants. So they have people that do this every day.
We're going to have time for a couple of questions only, since the time is a bit limited and we have to start with the opening ceremony. So ما تدفشوا بعضكم انتوا بس. Yes, Dr. Francis.
The protocol of Clasid, of Macrolide is not clear, the protocol of use. We would like to know on which rationale you use this drug. We can use it in everything. So this is only trials and trying to get something. Would you rely on PCR?
No.
Would you rely on
serology
structure? Would you rely on bronchiectasis? I used it in many bronchiectasis and really with good beneficial effect. But I'm not satisfied because I don't know when to stop, when to start. Will it be every second day? Will it be every day?
I'll try to answer as best I can, because I did actually go over the literature, and I'll tell you in each category where I think there may be some logic behind the way and the reason it was used. As you know, there are a lot of studies now ongoing. The clarithromycin is being added even to milk, I guess. I don't know. But it's used in VAPs, in the ICUs. It's used in a lot of conditions that otherwise you would not think about. And the whole idea is to try to use their anti-inflammatory properties. But I'll try to focus on the things where it seems to have an effect that has some bearing. In asthma, it turns out that it is effective where you can prove that there is an atypical organism. So even in most of the studies that you will review, you will find that they come from one of the major centers in the U.S. That's National Jewish in Denver, Colorado. It's the group there has done a lot of studies, has had a lot of interest in clarithromycin and other macrolides, and most of the studies are done from Denver. So they tell you that even in those patients who are severe asthmatics, who don't seem to be responding, do your best to try to get evidence for atypical infections, because that's when you can justify to yourself using a macrolide. If you don't have the facilities, because it's not easy to culture those bugs, it's not easy to detect them by PCR, it is a less yielding and more expensive way of trying to get them than, say, serologies. But there are many ways of doing it. But whichever way you have available, try to fish for those, for evidence for chlamydophila or mycoplasma. Because if you do find evidence for those, you will definitely improve your patient's condition by using a macrolide. Now, if you don't want to and you want to try it on an empiric basis, it's justifiable, but you would give a course that would probably be a couple of weeks, and that's it. So that's in asthma, which I think has some bearing. In the bronchiectatic patients or cystic fibrosis patients, I think the mechanism has a lot to do with the effect on alginate and the effect on the glycosaminoglycans and the disulfide bonds that bind that make the matrix, if you will, for the biofilm that Dr. Wackett discussed. Because if you can break down that biofilm, then you will be able to clear them, and then you may be able to make a difference in the burden of colonizers, the microbiota that we talked about. And that's why I think we have better evidence in cystic fibrosis, because the effect there is quite impressive. If you can evacuate those airways, if you can reduce the stickiness of the secretions, then you will make a major improvement, because your toileting will be better and patients will fare better. I think that's where it makes sense. And this probably is responsible for part of the mechanism why in COPD, like the Albert study that talked about azithromycin in COPD over a year, showed an improvement in exacerbations. Why? Because probably you're not allowing for quorum sensing, you're not allowing for biofilm formation in areas that are damaged, and therefore you may be contributing to a lessening of the burden of colonizers, and therefore reducing the risk of transferring them to an exacerbation or an infection per se, pneumonia or otherwise. So these are the areas where I think it may make a difference. Everything else is still anecdotal. In the ICUs, in VAP, in all those, I think it's anecdotal. We don't have evidence that can support their use on a wide basis. And I have to, again, caution on two fronts. The first, the side effects, especially with ototoxicity, say with azithromycin, long-term use, because here we're not talking about just using them for a couple of weeks. You're talking about long-term use. That second case that was several months. In the COPD study, the Albert study, a whole year. So you're not talking about a course, so BIMRO, you're talking about prolonged therapy. So you caution against the rise of bacterial resistance, and you caution against side effects, especially with say, ototoxicity or otherwise. I hope that that was of benefit.
And I think I should have limited the answers, not the questions.
Thank you, Mr. Chairman, for your...
We can have another question. Okay, I thank you all for attending, and I thank the speakers. Thank you.